Hello, good morning, and thank you very much for being back to Harbin. The video you saw was recorded at the normal time based upon the air traffic traces across the Asia. We were living a different time, and now we wanted to be back. We wanted to be back with what is allowed. And so we design with the incredible contribution of many friends, this hybrid live course. Why hybrid live course and what does it mean? We have essentially three different components. The central of this session is Stay in Harbin, led by the Cath Lab leaders, Dr. Hu, and the global department leader, Professor Yu and Haibo Jia. With them, we'll have some on-site expert from China interacting directly with them. And we will have also an incredible amount of faculties. These faculties are coming across the entire China, then across the Asia, from Hong Kong to Singapore, to Japan, to Korea, to Taiwan, and also from Europe, where you will see a couple of masters in complex PCI and imaging. Very important. We want to have a direct interaction, not only with the Cath Lab and the expert, but also with the audience. And the audience for us is very important, and we stay in touch with the child. Having said that, I wanted to give the ball back to the Cath Lab for opening this 2 days course on complex PCI and imaging by Professor Yu.
Good afternoon, everyone. It's my great pleasure to welcome Professor Guagliumi, Professor Eugene Wu, Jack Tan, Professor Akasaka, Tori, and all the famous cardiologists from China, Europe, and the APAC area to attend our hybrid leave course from Harbin on behalf of the Department of Cardiology of the Second Affiliate Hospital of Harbin Medical University. As the course director, our goal of this course is to share experience with intravascular imaging in daily practice through new cases to understand how OCT can improve PCI results with procedural planning and stent optimization. Due to the high risk and poor prognosis of complex lesion PCI, it's important to use intravascular imaging for precise guidance. Hybrid meeting include on-site live case in Harbin and remote deep discussion from APAC and European countries, especially thanks to Dr. Goran for your tremendous time and effort dedicated to this live course. I wish this program will have great success. Thank you for your attention.
Thank you, Professor Yu, for this introduction. And we are going back to the next explaining the essential concept. We say that one single image can tell you more than 1,000 words. So we fix one frozen image and then we send to everybody through WeChat or through Twitter to give you the essence of the case that we are going to discuss. And then we are going to get some sketches for identifying the most intriguing point. In this case today is diffuse disease and severe calcification. And you will see how the lab will approach this case. I was saying that you, the audience, are essential for us. So we launch a question through WeChat to Twitter, and we ask some question likewise, how would I treat this type of lesion with multiple answers? And we will have a clear look to this answer as well to any question suggestion you want to do through the chat. This is the format. Direct interaction between the cath lab and the expert and availability to relaunch questions or suggestions from the audience using the chat. Because we don't have enough time, what is coming next at the end of the course, we'll have an hands-on of the images acquired during the live case by on-site expert in streaming. I want to stop this blah, 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 and give the ball from now to the end to Eugene Wu, who will deal as lead facilitator of this session about diffuse disease with the calcification, how to assess and react. Eugene, up to you.
Thank you, Dr. G, for that kind introduction. So I think the calcium and diffuse disease becoming more and more common in our cath labs around the AP region and around the world. This is due to two main things. One is actually the ischemic heart disease is becoming in the younger age group. Patients are presenting with triple vessel disease and complex disease much younger than before due to the westernization of diet and these changes. Secondly, there's this new group of patients, the CHIP patients, who are coming to us because these patients, we used to just give medications. The surgeons don't touch them, we give them medicine. But now these CHIP patients are coming to us and we put in impellers to support them and we find the whole vessels through of calcium and diffuse disease. So we need to learn how to deal with these diseases, and imaging plays a vital role in this. So without further delay, let's move to the cath lab and look at the first case. So let's turn to the cath lab.
If you can stop sharing.
I haven't shared.
Oh, 切一下导管室. Okay.
Hello, Dr. Hu.
Hello.
Can you hear us? Hello.
Yes,
Greetings from all of
very
us.
clearly. Yeah.
Can you tell us what's happening? Yes, we can hear.
Yeah. Okay. I think that for this case is a very complicated case, and we will begin from the angio, please. And this first today, and we give angio to RCA. You know that we have stent implantation previous because it's inferior myocardial infarction, and for one stent implantation. Still some problem about RCA, but TIMI flow is very good. And so let's go to the left coronary artery. And you can see from here that this is from febrile, and for this patient with the very serious stenosis, very diffuse one along the circle. And this is LED. LED we can see a very diffuse stenosis. And from the opening site of LED to the just the distal side, and very, very long. And we must pay attention to a very big diagonal. And you can see here a very big diagonal, but the opening site of diagonal is just among LED and the circle. And maybe this is the just from OCT we can see that it's just from the beginning side of the LED. And from the angio, Professor Wu and Professor Guagliumi both share opinion about this patient, the treating strategy for this patient.
So I see there's a lot of calcium in this LAD. And
Yes.
so this is going to be a problem for us. So I think in calcium, imaging is very important. So in this kind of very calcified and diffuse disease, usually I will start off by seeing if an imaging catheter will go down, preferably a light-based imaging like OCT, because that gives me more information of calcium. So I think in these kind of cases for me nowadays, it's imaging first. If the imaging doesn't go down, then a small rotor bird, then imaging. So can an imaging catheter go down here?
Yes. We just performed the OCT examination for LAT and diagonal. Then first, I very fully agree with you about the OCT. It's very important for decide the calcified severity of the calcification. And this is the OCT of LAD from the distal to proximal part. You can see here, it's just a small calcified nodule, but not very serious. And here, you can see the calcified nodule here, and place the technician and just point it out. And then go to the proximal. We have some calcification, but not very big in arc. It's not more than 180 degrees. So after the OCT examination, we select for just LAD CVI calcification value index is not no more than 3. You can see clearly about the OCT imaging for LAD.
Yes, we can.
Yes, then go to diagonal. This is diagonal, and the distal diagonal is very normal and without calcification and lipid deposition. But from here, just now normal, yeah. Now with the plaque, but you can see here. Stop here, yeah. You can see very thick calcification, and it just 300 degree and one by one. Okay.
Yeah.
A very thick calcification. So here is near circle 1, circle calcification, very serious, and the millimeter lumen area is very small. So for diagonal, because very big, and here we want to see the opening site of the diagonal. The optimal is very good, like the opening site of the diagonal is good. So we can just very precisely to put stent here on top of opening site of the diagonal. But for the calcification of the diagonal is very serious, and the circle one are very thick. And CVI I think like is more than is 4. So maybe for diagonal, if we want to do PCI, we must do rota, and then we must using cutting balloon or NC balloon to make some fracture about the calcification. And the last one is stent implantation. So I want to know your opinion, and maybe we have still some problem to treating this patient for the circ. How about, do you think, how to do about the circ?
Well, let's address the LAD, calcium, and the diagonal first. Well, Dr. G is the real expert with calcium. So does he have any opinion for us about this LAD and diagonal?
Okay. So I wanted to go very quickly around and to listen the opinion on the other expert. I think we realized, for instance, we were focused on the LAD, and now we are realizing the importance of the diagonal, also in terms of calcification. And Dr. Hu was saying, well, it's a big branch, so it's not the fact that it is a diagonal. We need to treat it in some way with the calcification. That is segment calcification. The distal part is okay, so there is a segment that needed to be treated. But I want to ask also to Takashi if he has, to Professor Akasaka, if he has any comments. Ingan, the same.
Yes, diagonal branch is near the orifice. There are very thick calcium, more than 270 degrees, right? So I would like to, yes, do the debulking using a low tabulator to make, yes, ablation. Otherwise, it might be very difficult to put a stent in the proximal diagonal. The LED, we can identify the calcium, sometimes the thick calcium, but the angle is not so thick. Therefore, we can do some cutting balloon or swelling balloon to make a dilatation and then put a stent. It might be okay, I think. It is my impression in this from this imaging.
Ingan, any comment?
Yes, I agree with Dr. Takashi. I think the diagonal is really big. It's difficult to ignore the diagonal. It's almost, the calcium around the ostium. I believe to be able to allow us to correctly expand a stent, we need to modify it with rotablation. As for the LED, I would actually rotablate the LED as well. There is some nodular calcium in the mid LED, and all these will be easily modified using rotablation.
Yes, I think I agree. I think the since you've got the rotablator out already to do the diagonal, even if you just rotablate gently down the LEDs, just smoothen the tips of those calcium nodules so that you can make stent delivery and device delivery easier. So I think that's quite good. So why don't we go to the cath lab and see what they've done and how far they've got and what their plans are?
Yes, I just hear all the professors' opinion is very good, and so just based on OCT examination, we think that the IOED classification is not very serious. And so we first use the 2.5 balloon and to pre-dilate, and then use the 2.75 balloon cutting balloon and to with the 8 ATM to dilate the IOED. And now blood flow is good. And then we do OCT examination to LED. Now let's go to OCT examination after the pre-dilatation. Pay attention to the minimal lumen area site. 直接到那个去。Okay, here, stop. Okay, here is the most area of LED. You can see like the balloon and the cutting balloon. And now we have the fracture and the minimum lumen area enlarged very big. And so I think that the pre-dilatation for LED is very good. And so we just use OCT and ACR and to give us stent implantation at the distal part of LED. And from OCT examination to the distal reference site. From OCT examination, the distal reference site, the EL diameter is 2.84. So we choose 2.75 stent, and the length is 38. This is the implanting site. Okay, do you agree about the treatment for LED?
Yes, that looks very reasonable. In fact, this is what Professor Akasaka suggested, cutting scoring balloon, and then if that opens well, stenting. So what is your plan then after this and about the diagonal?
Yes, I think that because for the diagonal from the OCT examination, we must do rotablation, and so we didn't put another stent at the proximal LED. From the OCT examination, the proximal LED is now stable, and so because to the rota, we must get the gatewire of the LED out of the system, and so then we withdraw the gatewire of LED, and blood flow is good. But I just pay attention to very serious diagnosis about the circ. The circ is not stable. It's subtotal occlusion, and so because we have one result for this patient, if the LED stent from the OCT examination may be into the left mean, and so it can make some trouble about the circ, another stent implantation, and so we decide to the first the soul, the circ lesion, and to get where this is 2-pound balloon and dilate and 2.5 NC balloon and to pre-dilation with a good result. This is the 2.36 in length stent, and we put a balloon along just the marginal branch and to protect the side branch. And this is just after the implantation of the stent. And then the result is good. And then we want to do the post-dilatation of the circ stent. But after that, the circ stent is good, but the marginal branch is disappeared. And then I just put another gatewire into the side branch after the 2-point opening. Opening the side branch and after the casing and the main branch just dilatation, we have a better result of the circ and the marginal branch. And then because we have good result and now the blood condition is very stable, so we can pay attention to the rotablation of the diagonal. And this is
Hey,
the
Dr. Hu.
rotablation for diagonal. Okay?
Super. Dr. Hu, we wanted just to leave you working properly. We are switching back with Eugene to the discussion. Very interesting and challenging case. So Eugene, back to you and to perhaps see also what the audience is thinking about this case. Can you switch it to Eugene? Stop sharing screen from Harbin and give the ball to Eugene Wu.
雨涵那边切一下啊。
Okay, a little bit of time in switching. Let's go back from the Cath Lab to
把那边
Eugene.
的信号切到会议室来。
Eugene? Hi.
I'm Dr. Jian Liu from Peking University. Can I share my opinion?
Yes, please. Very shortly. Okay.
Okay.
Good.
So I think the proximal of RAD, the stent not very well expand. So before the stenting, maybe rotablation should be done in RAD proximal part. So I think after rotablation to first diagonal, maybe very heavy NC balloon to post-dilate proximal part of RAD stent is very important. And also for me, I will do circ first because we will cross over circ from the RAD to the left mean. So the result for the circ now is good enough. So maybe we implant stent all the way from RAD to the left mean. Thank you.
Okay.
Sorry,
let's
my
go back to
computer crashed
Eugene.
all of a sudden, Dr. G. I'm back.
Okay, so in your hands to have a look to the opinion of the audience. I think that we had a pool. How would I treat this lesion? And if you can resume your slides, share your screen. Eugene, you needed to share your screen.
Share.
And
导管师是不是在分享什么？OK。
Can you see it now?
Okay, and advance up to the point where after the cath lab, okay, go. Okay, the next one. So expert opinion, we listen, and we wanted to know about José also de la Torre, about the opinion on his strategy.
Yes, please.
Yeah, right. I think it's a nice demonstration that OCT may provide a nice picture of how the vessel situation is, particularly in diffuse and calcified lesions, where this is key to have the stents properly expanded and well opposed. Then with OCT, you can just select the lesions to treat, the landing sites, and the calcification profile. You see a very circumferential severe calcification with type reduced lumen for ablation is a good alternative. In those cases with deeper calcifications preventing further expansion of the stents, then shock wave technology like the lithotripsy could be best because maybe the lumen is more than 2 millimeters and then ablation is not going to be effective. In this case, ablation in the diagonal is a very good decision because it's a very tight lumen. The score of the OCT classification is high, was 4, because you have angulation of more than 180, you have length of more than 5 millimeters, you have thickness. In those cases in LAD, as Dr. Takashi indicated very well, that maybe because the score was less than 4, because there was no accumulation of verbs features with OCT. Maybe an escalated strategy first with non-compliant balloons. If this is working, is okay. If not, maybe you can go to rotablation, or I have the always alternative lithotripsy, and then you just can proceed to a stent expansion. And absolutely agree with the treating first of the circ, because you are going to jail maybe the circumflex with the stent from LAD to LAD, and treating also LAD, diagonal short, before treating LAD, because again, you can jail the diagonal, which this vessel, fortunately, is not affecting the ostium, it's just in the spot. Then I like the strategy based on OCT.
Excellent. Can we have Lesion's opinion to us too? And then we can discuss.
Yeah, thank you. I think it's a very wonderful case just for the OCT example, that because it's hard to evaluate the severity of the calcification only based on the angio. For this case, at first, I think that maybe only the LAD need rota, but the diagonal not needed that. But after the OCT imaging, I think for me, I prefer both LAD and diagonal to perform the rota ablation. And I think from the OCT, obviously, it gives us lots of information, have a long segment calcification of more than 180 degree and very thick calcification, and in some site that have a nodular protrusion to the lumen. And I think the OCT can give us very useful information to how the result of the preparation of the calcification and finally optimize the stent expansion. And another point I want to confirm from the OCT is the proximal landing zone. And from the angio, I think maybe from the caudal or the osteomal LAD, maybe we can land in the proximal standing. But from the cranial or the angio, maybe not. Maybe I think just depending on the preparation, I think maybe the standing should cross over to the left main. That's my opinion.
Yes, I think probably we understand that we have to stent into the left main, and therefore dealing with the circumflex becomes quite important, because if we don't deal with the circumflex, then we won't be able to stent. When we stent across the left main, we'll have great difficulty accessing the circumflex back again. So do we have any questions from the chat that we want to answer?
No, really, we can go ahead and check if we have a pool. So if there are no questions from the chat, we should have, I think, something shortly about what is worth.
Okay, so the question, of course, next is what is, in this kind of very calcified and diffuse disease vessels, what is the worth of doing imaging, and when should you do imaging? So one of the questions is whether you should do pre-intervention imaging. Now, for me, of course, all cases you need pre-intervention imaging, because pre-intervention imaging can tell you what's going on, what are the sizes, and what's happening, and gives you no nasty surprise. And especially in calcium, because very often the angio itself is not good enough for us to know whether you'll be able to open that calcium, whether there's a nodule that's going to be stuck to you. So it's almost always worth doing pre-intervention assessment in the calcific diffuse disease vessel. In fact, as I say, for me, probably these kind of vessels, the first thing that should go down is imaging catheter, because that's going to tell you what's going on. So this is an example of a diffuse disease calcified vessel. And this is a very important thing that we have to struggle with. Now, sometimes you see OCT gives you the answer, but sometimes it doesn't give you a very good answer, because even with some predilatation here, you can see what you see is a lot of calcium, a lot of disease, and it's very hard even to see the EEL in this kind of vessel. And in the distal part, for example, you can see there's the first image, you can see a little bit here where you can see the EEL, and it's a very big vessel with very diffuse disease. And there's nowhere in this segment that we image that's completely normal. So of course, the question remains, should we then use the EEL to choose our balloon and stent sizes, or should we use the lumen? Now, if you use the lumen, you end up with a stent that's very small, and by the end of the day, you might not even have achieved ischemic relief for this vessel. So this is quite important to think in terms of the vessel, what is worthwhile to get out of the imaging in these very calcified and diffuse disease. So we can see here on the left side, you have one measurement, the EL is about 3 and 2 to 8. And you can use that, of course, to do the stenting. And after you stent, of course, you can see much better where the EEL is and the vessel sizes. And so sometimes you can stent these vessels, and then post-stenting, you'll be able to do more accurate imaging, and you'll be able to see what's going on. So also, this is vessel looking at what you can see comparing IVUS with the OCT. And of course, IVUS, those of us who use a lot of IVUS and a lot of OCT realize IVUS gives you the EL more clearly in most cases. OCT is probably a little bit weaker. OCT is better to see the body of a calcium chunk and the back wall of the calcium. But in terms of EL, you probably get a little bit more from IVUS. But you can see in this Illumium 3 study that really both the IVUS and the OCT, we can see the EL in some reference segment most of the time. If you have the experience in the core lab, you can pick up the EL and IVUS 100% of the time, and in OCT 95% of the time. So basically, I think we can get quite good estimation of EL on the IVUS as well as the OCT. So after giving you a little bit of detail of what is worth imaging in the diffuse disease patients, maybe we'll ask some of our experts what their opinion is. So may I ask Dr. Jiaming Lu to share with us his opinion?
Yes, can you hear me?
Yes.
Okay. I think, of course, pre-intervention imaging is very, very important, especially in very calcified complex lesion. And just Eugene says that it can give us the situation of the composition of the plaque and the plaque length, plaque size, and we can give us a very clear picture and how to treat this case, and what decides what the stent size, stent length. And just like the demo case, I think that's a very wonderful case. And before from the angiogram, we just maybe we should do the rota for the LAD and the diagonal branch. But after we do the imaging, we can see that actually for the very tortuous LAD, the wire bias is not so suitable for the rotablasion. So if we do the rotablasion, if you see the wire bias not unfavorable wire bias for the very tortuous LAD, maybe we can take some risk of even the perforation. So, and we are surprising to find out that there are some severe calcium for the osteo diagonal. I think that is the value of the the imaging. It will influence our PCI plan. So that's my opinion.
Yes, very good. Exactly what as you said. I mean, I think on the angio alone, you couldn't tell that the diagonal was that bad, and you would thought the LED is worse. But when you put an imaging catheter down, you can tell the diagonal is worse and the LED isn't. Very nicely demonstrating the importance of imaging. So let's have Dr. Jiang Liu also give us his opinion.
Yes, thank you. My opinion, firstly, use OCT for the diffuse lesion is very important. OCT can help us to identify the lumen side of the distal and the proximal or the stent side, and also can identify the plaque, what kind of plaque we face, calcified or the other kind of severe plaque. And also we can know the size, the length, and the thickness of the calcified lesion. So it's very useful for the physician to have the decision to use like rotablation, cutting balloon, or screwing balloon to treat the lesion. For back to this case, I also agree we should do rotablation both to RAD and the first diagonal. But for RAD, my suggestion is only do the rota for only proximal part, because distal is a total long lesion. It's very easily to cause the perforation. And also, we can use cutting balloon to achieve very good result. So my suggestion, this situation to be cautiously post-dilate with a proximal RAD stent because it's under expansion. And for first diagonal, because it's very straight and also very severe calcified lesion, rotablation is not very difficult, but still is a set branch. So cautious with the perforation is very important. Thank you.
Oh, that's I like his this ideas. It's very good. So the imaging guides you in terms of what you do in each segment. So the distal LED very tortuous, so you might use a lithotripsy balloon. The proximal the LED is more straight and the calcium not so bad, so gentle rotablator. The diagonal very calcified and concentrate on the imaging. So we need rotablation, but we need to take care. That's a very good opinion. So let's move on to the next stage, which is to look at really what is worth assessing. And this, we're going to do a little spot poll from the WeChat to see what is worth assessing in the diffuse calcified lesion. Is it the eye-catching lesion, the severity and extent? Is it to achieve the minimal lumen for imaging? Is it to detect areas of severe calcification? Is it to make a decision about the physiology and anatomy interaction? So maybe we can take a poll, and Dr. Haibo can tell me what the poll is like.
Okay, I will share my screen.
Okay, let me stop sharing mine
Okay,
first. Okay.
I will share the result of the polling here. Yeah, this is here the result. So can you see my screen?
Okay, so
yeah, here the result. I think
yes.
Yeah, very consistent with the opinion of the expert. So ideally, I think combined physiology and intravascular imaging may be a better assessment for this kind of very diffuse disease, also very calcified lesion, and also of course imaging. So about 50% prefer physiology combined anatomy interaction for detection, decision making.
Yes, I'm very happy to see this. I tell you why. Because I'm always worried that people are not willing to adopt the new technologies for coronary intervention. But I'm very happy to see almost half the people understand the importance of anatomy physiology interaction. Because I've been doing a lot of cases with OCT-based imaging, and I always try to do cases perfectly so that the distal and proximal stent edge are in normal segments, that the stent has been placed to Lumen 4 standard expansion and apposition. But sometimes I find even after that, when you put a physiology wire down, the RFR wire, it's still abnormal. So it's very important to have the balance between anatomy and physiology, and especially in diffuse calcified disease. So nowadays, if I see a diffuse calcified LAD or a big right coronary, I'll almost always do a resting indices at the end of my intervention to make sure that I've achieved physiological revascularization. So that's important.
Okay.
So maybe we can.
Yeah.
Are there any comments about this? Otherwise, we can go on.
I have a comment because this
Go
is very
ahead.
nice to see that the people really demands, and it's absolutely understandable, the physiology and anatomy, because in these diffuse lesions you have to select the targets for PCI, and physiology is the best to define the severity of stable lesions. And imaging is going to be the strategy, the tool to plan the PCI procedure. But now we have developments in software for OCT to do the job of the pressure wire. And there are interesting studies published showing that with the OCT pullback, you can make estimations of FFR, let's say OCT FR derived parameters. Then very soon, maybe we will have only one tool for this functional imaging interaction with OCT. Now we need the correlation with IFR or whatever combined to imaging.
Yes. Okay, so let me. I'll go back to my screen. Oh, point. So the next consideration is this aspect of the morphology of the plaque and how it affects our intervention and how it affects our use of imaging. So there's a range of disease that we deal with in the cath lab. There are some cases which are very normal, a little bit of lipidic plaque, and it's not very calcified and it's very simple. Those cases we may even consider direct stenting. If you find that some lesions, there's some calcification, but not a lot, maybe there's some fibrotic cap, then you might pre-dilate with a compliant balloon before you consider stenting. In other cases where you start getting some more calcium or deep plaque, sort of like this kind of arrangement, you might need to use an NC or a scoring balloon. And in the very calcified, like the diagonal we have in our live case, then those patients need arthrectomy. So there's a sort of range of complexity in the coronary, depending on the plaque morphology. And this dependence on the plaque morphology changes what we need to do. But the problem is, angio doesn't give us this information. To know that a plaque is only lipidic, is fibrotic, can be easily done, you really need imaging. So imaging can actually help you classify your case into what kind of case it is and what sort of pre-treatment you need to do to this. So let me get to this is the calcium scoring system, which we need to be familiar with. I'm sure a lot of people are already familiar with this. Calcium can be divided into eccentric and concentric calcium. And the eccentricity and concentric calcium changes whether you need to do upfront preparation. So there's a lot of many different papers doing different types of calcium score. This is a simpler sort of calcium score, which is based on the degree around the vessel, the length of the calcium and the thickness. So if you have an arc of more than 180 degrees, then you score 2 points. If you have a length of more than 5 millimeters, then you score 1 point. And if you have a thickness of more than 0.5 millimeters, you score another point. So the higher the points you have, the more likely you're going to need to use arthrectomy based on this. This is, I think, a very easy and friendly and easy to use method to see when you need to do more than just ballooning for calcium. So let's go back to our cath lab and have a little look at how we're doing with the case and have an update from them. So I'll stop my sharing, and can we go to the cath lab again? Dr. Hu, can you hear us? How are you doing?
Yes, I
It's
can
looking
hear
very
you.
nice.
Yes, we just
So-
but we now with some problem. One by one, I just back to the diagonal. And you know that from this case, I know that imaging is very important. But imaging it's not all the things. And you know that from the diagonal OCT examination, we must do rota. and then finish the circle. The circle we give us stent implantation with the bifurcation protection, and so we get a very good result. And then we do router to diagonal. This is the 1.5 router, and with the speed is the 160,000. And so after 3 times of router, and then we do OCT examination. And you can see here is after the router for the diagonal. It's really a good result. And we can see the router, get a circle. Okay.
Oh yes, very nice.
Yes. But very nice, but without the big fracture. And you can just circle calcification. Calcification is thinner, but not with the big fracture. And then we do NC balloon dilatation, 2.5. So after the NC balloon dilatation, we see some fracture of the calcification. You can see here. It's the fracture, and it's the enlargement of the minimal lumen area. And so we do ACR for the diagonal, and so after that we choose from the OCT measurement, choose the 2.75 and 33 stent. Just from this position is very precisely at the opening site of the diagonal, and you can see this is angle. And after this is the balloon, and you can see the middle part of the stent without a good expansion. After that, and we use the 3.75 NC balloon and to post the dilatation to diagonal stent. And from the angle, I think that is a good result. Do you think so? Yeah,
Yes,
but after the OCT examination, you can see here. It just go to the minimum lumen area. The distal side of the stent is very good. The diameter is very precisely. And so from here is a minimum lumen area for the diagonal is 3 near 3 millimeters square. And so I think that for the big diagonal, we need a better minimum lumen area. And then we do post dilatation with very high pressure and to 28 ATM and with a long time. And so after that, we do another examination. And here we have a better minimum lumen area. Go directly to. Okay, you can see here we have a better result. I think that can you, Chairman, and can you see this result for the diagonal? I think that is a good result. I now will pay attention to the LED. Do you think so?
A question for Dr. G. He's the expert in this.
Okay, Dr. Hu, you pointed out something that is very important, how difficult it is to deal with the calcium. You use a rotational atherectomy, then you say that we did some cracks, you show some crack, but the lumen is not open enough. So I will go with some additional balloon dilation plus stenting. Very important in my view is any steps to take care about the size of the lumen, and then to see if it's better to escalate in with a rotational atherectomy, or if it is enough to switch to something like a cutting or a scoring balloon to open up. The price that we are paying many times at the end is that the calcium was not totally ablate and or crack, and we still needed to learn a lot in terms of these results. But it's extremely important to have these sequential images from your side to understand what should be done.
So
Yes, okay.
my question is, So for Dr. G, at this point, you have a AS of 59%, but it's a diagonal, and she's already gone to a 3.0 balloon. Is that right? Up to 20, up to 30. So what would be the maximum balloon you would go, and what sort of pressure?
So in terms of strategy, but perhaps I'd like to have Jose also involved. If you still have a calcium constricting asymmetrically the vessel, well, it's not easy at this point. One of the chances is to go with IVL if you're trusting on the effect, but there is also some potential damage induced to the polymer on the stent, and so that is really questionable. We don't have data. And so I think that before implanting the stent, it's very important to be sure that we optimize the results. Jose.
Can I have
it's certainly true. We have more and more cases what we call rotatripsy cases. In those cases that you do rotational ablation, you just dilate with the balloon, and you don't see full expansion of the balloon. Then you just don't go to the implantation of the stent, that you maybe have to do additional dilatation. But in many cases, even non-compliant balloons are not enough, and then short wave balloon with a well-adjusted size is able to crack this deeper calcium, and then the stent is properly expanded afterwards. Now, as a bailout, like in this case, maybe again, a short wave could be an alternative to crack the deep calcium and to further improve the expansion of the stent. Other people is even using laser, excimer laser, but personally, I prefer short wave, like a trichy to resolve in circumstances when rotational was not enough.
Yeah.
Yes, that's a very good comment. I'm going to get Dr. Akasaka to comment on this, because it's best to do it before, isn't it? So please comment to us.
Before.
Already, yes, putting a stent now, right? So we do not have enough way to treat more, right? Because I'm afraid this is a very thick eccentric calcium, and the opposite side to the calcium, it is already enough expand. So if you dilate more, we will have a risk of perforation. Therefore, we have to. It might be acceptable at the moment, I think, but if we put the
I have one more question for Dr. Akasaka. Is there anything in the post-rotor imaging that can help you to know whether you need to do more? Because now the question is, we shouldn't have stented. We should have done something after rotablation. Is there anything in the after rotablation imaging that will tell us we need to do more rotablation or more something else? Can you comment on that?
Right. If the calcium is still nearly circular, we can use a shock wave to make a further crack. And then we can dilate more. But in this case, very eccentric and thick calcium. Therefore, we have to accept in this condition, right?
Okay. And I think that is wise. At some point, in some times when you have very eccentric calcium, you have to accept. Otherwise, you end up with a perforation. If you try to do aluminum 4 standard, you end up with a perforated vessel. So let's return and ask the cath lab how they're doing. One last bit before we move on. So, Dr. Hou, we want to catch up on how you're doing, and then we'll leave you very soon and come back later. Can you update us a little bit?
After the diagonal, and we finish diagonal, like for this patient, if this patient is just one vessel calcification, maybe my aim is a very perfect result. But for this patient is 3 vessel, and like the LAD and the diagonal and the circle and the marginal, I must pay attention to 4 vessels, and I must pay attention to the safe and the contrast volume for this patient. And so I just want to get 80 score for this patient and not 100 score. And so after that, after diagonal, I just used the NC balloon and 3.0 and to predilate the proximal of the IOED. And then from OCT examination, which was 3.5, 36 stent, Just from this position, just the cranial position to put precisely at the opening site of that mean. And then this is after stent implantation. And you know that just two parts, the distal left mean and the middle part of LED is from the angle, not very optimal area. And then we do the post dilatation. This is 3.0 post dilatation NC balloon, and then 3.5. And this is after the post dilatation. And then we do OCT examination. And now you can see the result of the OCT examination of LED, the middle part, okay, from the distal again. The distal stent is very good, and you can see here is circular shape. And this is just the middle part. You can see from OCT examination, we have a good result for fracture, but for the thickness of the calcification, at one margin is very thick, but another margin is just normal, and so it just push the calcification push into the lumen, and you can know that it's a regular shape, but the minimal lumen area is good. 看最小管腔面积。minimal lumen area is 3.82, and so I think like it's enough, and maybe we can do FFR to make sure, but I think that is enough for middle LAD. Now let's go to the proximal LAD.
So let's move on. Let's move on, Eugene, and
okay. So we'll leave you to
Guang.
finish, and then we'll move on to the other case. So we'll come back to you and look at your final results in a moment. Okay. Okay. So thank you. Let me try to share my screen. So they did it very well. So next, let's have some comment on lesion preparation in for calcified lesions. So can I have a quick comment from Frankie Tam?
Yes.
Frankie.
Hi. So this is a case, a tough case, but beautifully done. So I think for LAD, the main problem is actually the deep and eccentric calcium. We can see that the wire bias is actually not very nice. So I think for a road ablation, it's not very effective unless we use a very big burr. So I think in this case, they use a balloon-based strategy, which is completely fine. Of course, with this eccentric calcium, we have to accept that. I mean, at the end of the day, the stent has to may not be completely expand, but for them, they have a very good MSA achieved. And for the diagonal, I think a very tight lesion with more than 200 millidegree. So I think road ablation is very useful. But again, there's a very thick and eccentric calcium just distal to that concentric calcium, which again, we have to accept this in some cases like this.
Yes, I think that's a very good comment. So I think both Professor Akasaka and you make the same point that if you have very big eccentric calcium, sometimes we have to accept it. So our other expert commentator, Lim Han, can you give us your comments on this lesion preparation issue?
Okay, yes. So first I want to congratulate Dr. Hou for a really good case there. This is a very highly calcified diffuse lesion. I think it illustrates two very important points. The first point is the importance of lesion preparation as demonstrated by what we see in the diagonal lesion. If we can look for calcium fractures, that's one of the most important predictors of whether the stent can expand. Because if we implant a stent before the lesion is properly expanded, a lot of times we have difficulty expanding the stent. Okay, this is important because of there's a lot of data showing that some of the important predictors of DES failure is stent under expansion. For me, the short-term risk. I mean, the data shows that short-term risk is of under expanded stents is a higher risk of thrombosis or acute stent failure. And we also know that the long-term problem is that of restenosis, and restenosis has been shown to be correlated with suboptimal stent expansion. And so bearing that in mind, lesion preparation and highly calcified diffuse lesions is important. Now, the case also amply demonstrates how intravascular imaging with OCT can help us determine and predict complications if we see as much calcium as this without proper lesion preparation. Sometimes with just plain NC balloon dilatation, it can result in vessel perforation as one of the complications, huge dissections, or in the use of rotablation, burr, and entrapment. So this case amply illustrates why it's important to use intravascular imaging to look at diffuse calcifications.
Yeah, that's a very good point. I think again, the imaging helps you choose the type of preparation you need. So I can't see the chat when I'm on this. Are there any burning questions from the chat, Dr. G?
Well, there was a burning question, and that is, okay, the question from the audience is, what is a uniform standard as to which calcification lesions are suitable for rota and which lesions are suitable for cutting balloon according to the OCT imaging? Who want to answer? Jose.
Yes.
I think that we mentioned something related with this. I think imaging OCT is perfect because when you see the score of all the components of the negative features of length, more than 5 millimeters, more than 2 quadrants, more than half millimeter in thickness, then you are in a high risk of substantion. Then you need maybe rotablator, but rotablator is useful and effective if the lumen is really reduced, is decreased, is the calcium is superficial, and the lesion is tight. In that case, you go for rotablation. But if the calcification is deeper, and the lumen is relatively preserved, then rotablation is not enough. Maybe you have to start with balloon. And not only cutting, but we have the short wave balloon that is more effective in calcification compared to cutting or to scoring balloons. And then we have circumstances in which we need both, because we start with superficial, very tight calcification, you do rota, and then, like in this case, in the diagonal, further the dilatation demonstrates that it's not enough, and then you need a new tool apart from additional to rotablation, which is cutting balloons or again lithotripsy. Then, to start with, you have certain idea, but this is very dynamic. But please, my message is before implanting the stent, we have to demonstrate that the balloon is properly expanded at that site, because otherwise we are going to be in trouble.
That actually links in very nicely with the next part of the talk. So I'm going to jump in here. And that is really the imaging helps us tell what type of calcium it is. And what type of calcium on the imaging helps us tell what techniques we should use. So in a sense, Jose just now mentioned exactly this. The deep calcium you see, then the NC balloon, the lithotripsy balloon, that works very well. For nodular calcium, rotational atherectomy or rotor atherectomy works very well. For superficial calcium, both the lithotripsy and the rotational and orbital atherectomy works well. So really, Jose did this slide for me, but that's the whole point. And of course, the presence of nodular calcification, extreme nodular calcification, is a particular problem, as in this kind of case. I find that there's two problems with nodular calcium. One is that it prevents expansion of that area, and two is that it prevents delivery of devices. And my approach to nodular calcium is, if the problem is that it's blocking the delivery of device, it's very rough, then I think rotational atherectomy is the best tool to get it down. If the problem is very big and is occupying the lumen, then I think orbital atherectomy is better to deal with it. So let's move on to the next vote question, and that is, how would you treat nodular calcium, rotational or orbital, cutting or scoring, shockwave, or depending on lumen size? So I'm going to get Apple to help us again to try to do this, and I'll stop sharing.
Okay, I will show you the result of the poll. Okay, here. here we have the result.
That's very encouraging because
Yeah.
a lot of people agree with me. Rotational and orbital atherectomy is better. I guess also depend on size is very reasonable too, because if it's very big, rotation is not going to touch it. So they are very good audience. They already know a lot. So maybe let me go back to screen share and then we can ask the opinions of this very difficult question, which is the question of the nodular calcium, how to deal with the nodular calcium, that particular problem. So I'm going to ask Professor Akasaka, how does he deal with nodular calcium?
Yeah, it's a very important question. I think yes, as you told us, right? Yeah, nodular calcification. It's depend on the wire position. Yeah, sometimes the rotablator can work, but if we can use the wire bias, sometimes orbital atherectomy works very well, right? And nodular calcification and the calcified nodule might be different, right? Calcified nodule, including the red thrombs. At that time, I'm not sure at the moment, but the laser atherectomy may works very well. So we have to, yes, decide, depend on the OCT image and the wire position is gives us a very important information.
So Professor Akasaka is really the true expert in this. He's thinking about wire bias as well as the calcium material. So we have to reach for his standard. That's a very good answer. Maybe we ask Dr. Yukao, what do you think?
Thank you. I think this is a very good question about the nodule classification. When we make the nodule classification, I think maybe it's make a problems to deliver the stent and cause the stent arm expansion and maybe cause the later thrombus and the worst long-term results. And we also most of the time we use the rotor can solve the problems. Sometimes we according to the imaging, OCT image or the iris imaging, we found that the casting is against the nodule calcification, as we use rotor can easily to erase or decrease the nodule calcification. And if there is far away from the other side of the caster is away from the nodule calcification, maybe you use a larger burr to rotate the lesions is still cannot get a good results. Sometimes we just leave it to use a cast, use the big balloon and use a long complement the balloon to postulate the stent and gets a good lumen.
Yes, thank you. I mean, I think you're right. The large burr rotor is sometimes often neglected, but in the nodular calcium, the large burr rotor sometimes work quite well. So at this point, I'm going to hand over to Dr. G to do his little bit on the new technologies we have. So do you want to take it away, Dr. G?
Okay. Can you see my screen?
Yes.
We are jumping into the future, but the future is now. Everybody was talking about calcium, how to scoring, how to judging, how to make the evaluation. This is an example on how much artificial intelligence, or if you want, augmented reality, can help us in doing the job. This is the automatic detection in the new coming software, showing how nice the calcium can be detected and identified by encircling in orange, and for each section telling you the circumferential angle and the maximum thickness relief. And in addition, at the same cross-section, you have the display on your co-register angioimaging. If you are going back and you change the position of your calcium, you are going to get a different type of assessment. Calcium now is less encircling, is in a more different region. And then if you are going out for the region of interest, you can see that the calcium is going to be much more limited. And if you wanted to get some vision where you are outside of the calcified segment. So we think that that is very important. This is one significant contribution that we might get from artificial intelligence. The other ones is in EL. It was debated quite long the value of the EL and the lumen in a diffuse disease. Now we have in the display the detection, the automatic detection of the EL beside the automatic detection of the lumen. EL in this dashed line going around. If you want to see if this evaluation is corresponding to the reality, you can see clearly the same segment that when we detected the EL is clearly showing the EL also at the high ball assessment. But of course, we are going to get much more precision in terms of measurements and in terms of detection. So basically, I think they are the major information that in terms of plaque identification and characterization and guiding the procedure by using size measurements can be obtained now from the new coming system. Ball, back to you, Eugene.
Okay, so our time is running a little bit short, so maybe we'll have a faster question. Maybe if the two experts can tell us one thing that they want for AI technology that can help with imaging. So whether you want calcium or EL, whatever you want. So what is the one thing you want? Maybe we have Lesion tell us first.
Yes, thank you. The AI techniques, I think, is a very exciting and hopeful technique. Makes me feel that some hard work before is a waste of time. I think for me, I think the calcium, the AI technique used to evaluate the calcium is very useful for me. It's a top
Thank you. So maybe Frankie, what do you think? Which is the most useful thing to do with AI?
Yeah, so I think that software AI is very useful. I'm just wondering, will that AI teach us with what effectively should we use, what the size and length of a stent? Is it the virtual stenting maneuver there?
That's very future looking, but yes, it's possible, of course, because you can teach the AI all the subsequent devices and how the outcomes are, and you can use the expansion of stent to do this. So you're thinking very far forward. I like it. That's very good. But yes, eventually, I think to guide treatment would be what AI would really be powerful in. So let me carry on, and this is the sort of slide just to show you really the difference between IVUS and OCT in terms of looking for these calcium cracks. And of course, those of us familiar with IVUS, we can see the cracks on IVUS too. But on OCT, the cracks are just so much clearer. So nowadays, I rarely use IVUS anymore for calcified lesion because OCT just gives you such better images. So calcium fracture and its effect on the stent expansion. Maybe we can have a brief response from Professor Akasaka.
Yes, thank you very much. It is a very important question, I think. Yes, to make a calcium fracture is very important to get a good stent expansion and symmetricity. If we can get a good stent expansion, restenosis and the target lesion revascularization should be reduced, right? Therefore, now how to identify the possibility to making a fracture is already someone said the scoring system, especially the thickness of the calcium is very important. Anyway, after the tabulator or orbital trial after debulking the calcium, if the thickness become nearly 500 micron, we can make a fracture by using cutting balloon, squatting balloon, or non-compliant high pressure ballooning. So calcium fracture is very important to obtain a good result, good stent expansion. Yes.
Thank you. That's very useful. And can we have our opinion also for Lim Han?
Yes, I would like to echo what Dr. Akasaka just said, that calcium fracture is the single most important parameter to look at to predict stent expansion, and that directly results in us lowering the risk of stent failures long term. Now, yes, there are scoring system, OCT scoring that we can use. We'll look at the calcium thickness, calcium morphology, as well as the length of calcium to predict what type of debulking device we can use.
Excellent. I think you put your finger on it. I think it's the calcium fracture that really matters. Let's go back and see how our case is doing in the cath lab. Can we turn to the cath lab?
Okay, can you hear me?
Hello, yes. Give us the
Yes.
results.
Yes, I think that I just hear about your discussion is very very perfect. And so then we give the post dilatation to the LED and the left main stent with 3.5 post dilatation. After that, for the proximal LED and left main, you can see the OCT result. The result is good and with good shape. For the left main here, left main is good, but 你到那个该换机器 ，OK。Still the middle part of the LED, we have the minimum lumen area is about near 6 square millimeter here. And you know something like for this patient, for the LED is the deep calcification and the calcified nodule. And but if the calcified nodule is the minimum lumen area is not so big, the delta can't show such kind of calcified nodule. And so for this patient, we use the cutting balloon to pre-dilatation. But for the deep calcification, and I think that the router and the cutting balloon is not enough. Maybe the shock wave balloon is just suitable for such kind of deep calcification. But now in China, and the shock wave balloon is not available. And maybe for this patient, next time, if the patient with the restenosis along the middle part of the LED, maybe we can use the shock wave balloon and to solve it. But now, I think for this patient, because we just for this procedure, LED, diagonal, and the circle and the marginal branch are the 4 vessels, and just in a short time, we saw 4 vessels, and so I think that the result is acceptable, and I want this patient for 1 year follow up for angio and OCT examination.
That's fantastic. I don't think you have restenosis. I think that's a big enough lumen for that LED. So I think you did a very good job. You're very, very fast, you know. We are catching up with you. So we thank you. That's fantastic. I think any other questions from the panelists or Dr. G for the cath lab?
So I think that number one, congratulations to Dr. Hou. He is always reassuring to have here working while we are debating and discussing. She's a tough worker, as you have seen. So I think that is the best comment is to have a look. We are going back to last comments on the results from expert and how to make amelioration on what we are getting now by using imaging.
Okay, thank you very much. So let's move on to our expert. So I'm going to ask the opinion on what we've learned, and I'm going to ask Jose Latorre to give us his opinion first.
I think they did a great job, maybe the best they could get. It's important a compromise between the optimal and the ideal. because if you pursue the idea of things, maybe you get a vessel perforation and disasters, no? And how they did the best, they get the best from the imaging, from the OCT to select the strategies and to see the gain of the different steps, not to repeat the imaging. And you have to do OCT several times in the procedures like this, in very complex PCI. And finally, to get the best acceptable result, always looking for the safety of the procedures. I think the message is use OCT, use imaging to guide these complex procedures, and you get the best.
Yes, that's a very good message. I think the thing I like most about this case is how the angel would have predicted that the LAD would be the difficult one, but if you image, you found out the diagonal was the one that needed rotablator. So it shows you how imaging can change your plan, and by changing your plan, give you a better result. So I like that case very much. So the next thing, I'm going to quickly present the 3-year outcome of the ultimate trial. So you're all familiar with the ultimate trial. Basically, the 3-year result is a carry-on of the first-year result. And that is that IVUS guidance gives you a lower target vessel failure compared to angio guide. But also interesting to note in this study, of course, is that even with IVUS guidance, there was a significant number of suboptimal PCI, and suboptimal PCI also gives you a worse outcome in terms of target vessel failure compared to optimal PCI. So maybe now we can hear, knowing that suboptimal PCI is not good, maybe we can hear from some experts how the changes in imaging can reduce the rate of suboptimal PCI. So can I ask John Gui to give us his opinion? He's not here.
Ask Fei Ying.
Okay, Fei Ying maybe.
I'm very happy to be here to learn out. So for me to express my opinion is intravascular imaging guided PCI for the complexity, especially for the diffuse calcification is very, very important. So we should use the intravascular imaging step by step to along the whole procedure of the PCI, and especially for the calcified lesion, make sure which kind of lesion preparation is important before staining. So we should make sure that calcification fracture before staining is very important. Another is optimal balloon expansion. I mean, the size of the pre-dilating balloon is very important. The ratio of the size of the balloon to the reference vessel diameter is nearly or equal to 1.1. Different segment, different reference diameter, different size of the pre-dilation balloon size. So I think intravascular imaging used is not equal to the intravascular imaging guide. So we should use intravascular imaging step by step. Thank you.
Thank you. That's a very good comment indeed. So we are coming near to the end of this as we are running a bit over time. I want to remind you that after this session, we have a hands-on review of the cases. Those who want to join with that can do that. And so this is the thing we learned, is that the importance of using imaging in the diffuse and calcified lesions. And I want to stress 2 extra things. One is, of course, the importance of doing a pre-intervention imaging. And secondly is, of course, to do it as Yifei said, step by step, imaging and image gain, so that we can optimize the result. So I want to thank you all. I'm going to give Dr. Hu a last word from the cath lab, and then I'm going to thank you all and close the session. Is Dr. Hu still in the cath lab?
Here. I'm now in the
meeting
you're
room. Yeah, very fast.
Yeah.
Okay.
I just fly here. Okay, I think that for this case is very complicated, but everyone notice that the OCT imaging just change the treating strategy for this patient. At the beginning from the angio, everyone think that maybe the IOED need the route ablation, but after OCT examination and the IOED, maybe we can use the cutting balloon and NC balloon or shock wave balloon. But the diagonal, we must do the route ablation, and after the route ablation and cut NC balloon, and we get a good result for the diagonal stent. And so I think that for calcification, very serious calcification patient, and the OCT guided lesion preparation is very important because we can get the calcium volume index CVI. If the CVI is less than 3.3 score, and so we need the scoring balloon, cutting balloon, and to get the fracture of the calcification to get the enough stent area. But if the CVI score is 4 or the very serious calcified nodule in the minimal lumen area, and maybe we need the rotablation, acetectomy, or the laser. And so after we make sure about the big fracture and enough minimal lumen area at the circular calcification after the preparation, and we can go to the stent implantation. And so after the preparation, we must do OCT, the second OCT examination for the optimal result about the measured fracture and enough minimum lumen area. And then after stent expansion, and we make sure about the good expansion of the result. But I think that maybe for very serious calcified patient, and maybe the safe is most important. And just for this patient, maybe we need many kind of preparation methods, such as the cutting balloon and NC balloon and rotablation and post-dilatation. But I think that not perfect, but the patient without perfection and get good result. And this is the final result of the PCI for very complicated patient. Thank you all.
Thank you. I think let's all express our thanks to the cath lab staff and to Dr. Jingbo Hou and Professor Yu for a fantastic case. I think she did a beautiful balance between safety, imaging, and also speed of doing the case. So that was very nice. We appreciate it greatly. So that remains me to thank everybody for joining us. We want to thank
Eugene, may we say that, sorry to interrupt you, Eugene, may we say that tomorrow we will be back at the same time for another very exciting case about left main and bifurcation. So if you want to join us, that will be a great honor. Thank you very much.
At 4 o'clock. So thank you for Professor Yu. Thank you for everybody, all our panelists. Thank you all. And we'll see you tomorrow if you join us at 4 o'clock. Bye-bye.
Okay. Thank you. Bye-bye.
Haibo, can you hear me?
Yes, yes.